Hello. One of the hot topics in medicine is physician aid in dying. Today, I'm going to give you what you need to know about the End of Life Options Act, or EOLA, and update you on the changes in the law that went into effect this year. Hi, my name is Howard Homler, and I'm an internist who's been in the Sacramento area for about 39 years. I'm currently the medical director for the Sacramento branch of Accent Care Hospice and Palliative Care, formerly known as Seasons Hospice and Palliative Care, and I participated in the End of Life Act with patients for several years. Let's start out by speaking a common language. Euthanasia is when a healthcare provider administers drugs to a patient with the aim of killing him. This was Dr. Kevorkian's way of helping an ill patient. It was and remains illegal. Suicide is when a patient takes his or her own life, and it has important psychological distinctions. It too is illegal, although prosecution is challenging. Terminal sedation, sometimes called palliative sedation, is rendering a patient unconscious with strong medications with the primary intent of relieving suffering. Now, death may happen, but it's not the goal. We are using just enough medication to be sure we're controlling symptoms. If death happens, it occurs by what we call secondary intent or intention. We're going to talk today about physician-assisted death, and when I refer to the attending physician, this will be the one prescribing the drugs and doing the required paperwork. Why do patients consider this? These are some of the reasons patients give. Notice that pain isn't a strong reason. That's usually pretty well controlled. Now, what exactly does this law do? Well, of course, patients have been able to ask their physicians to give them pills to end their lives, but it wasn't legal for us to do so until now. Where did this all come from? There's been a strong public outcry for this, and as of the end of the year 2020, 2,800 Californians have received such prescriptions, and without any evidence of abuse or coercion. Unfortunately, there are many qualified terminally ill patients currently wanting this, but not able to find a willing provider. Now, obviously, there are strong arguments, moral, philosophical, and religious on both sides about physician aid in dying. And what you may not realize is that not all hospices support a patient's involvement in this process. The reason usually is because it adds to the potential stigma about hospice care. Some folks feel that if good comfort care is provided, folks wouldn't seek out physician aid in dying. However, this clearly isn't the case. In regards to bait and switch, unfortunately, I've seen cases where patients were referred to hospices that initially promised that they would support physician aid in dying, but only later told the patient, no, we don't do that. Then it was left for the family or patient to scramble around to find another provider who would. Well, let's talk about what should you do when a patient brings this up. These are my suggestions. This is just good medical care. And it's interesting to note that in the VA, they're not allowed to even talk about this. If you're not comfortable with this, you can refer them to other resources on the web or to other providers. And we'll talk about how the new law impacts you in this case. But remember, there's no penalty for not participating. The new law, though, says that you must inform your patient of your non-participation and document the conversation and your reasons for not participating in the medical record. So that's an important thing to know. Now, suppose you decide to work with your patient. There are things that you do need to know. First of all, who is this act for? These are the basics. An adult California resident with an incurable terminal disease with a prognosis of less than 6 months. This would automatically qualify them for hospice care. They obviously have to be competent to make an informed decision, and this excludes, of course, people with advanced Alzheimer's disease. They have to be provided with informed consent. Ironically, I know that sounds strange, but typical. We have to inform them of the risk of taking a drug that's designed to kill them. And in truth, there can be problems if they don't completely ingest the full amount. They may just fall asleep, or they may aspirate, etc. But generally, the purpose of the medicine is to end life. They must make these requests themselves. It can't be done for them. The doctor is supposed to meet with them to get a direct request. They have to be able to self-administer the medications. And this is why timing is so important. As people get close to the end of life, they lose that ability and then are no longer candidates for the End of Life Option Act. And it's important that if the patient's in a facility, that the facility is okay with their resident doing this. Well, to make it easier to go through the requirements and all this, there is a checklist for the physician to follow, and I actually take a copy of it with me when I do interviews for patients who are asking about this. I just can go through line by line. There are some restrictions, some additional requirements. Again, the details of all this are on the checklist. Let's review the sequence of what happens. The patient has to make 2 separate verbal requests in person with the attending. These days, telemedicine is acceptable. Prior to January, the timing between the verbal requests was set at no sooner than 15 days, and many patients died before they could make that second verbal request. The new law reduces this waiting time to 48 hours. And that's a big improvement. There is also a witnessed written request with only one of the signatures of the witnesses can be a family member, and no healthcare provider can be the other witness. So usually it's a friend or neighbor. Now the attending then determines eligibility. We talked about eligibility in the previous slide. A second opinion is necessary to confirm eligibility, and this is from another doctor. A second opinion from mental health is only necessary if either physician determines that there is an underlying mental health issue that is clouding the patient's judgment. Otherwise, mental health consultation isn't required. We obviously screen out people who are just plainly suicidal. The next step is that the attending physician speaks to a pharmacist and sends in the prescription, usually to a compounding pharmacy. And then the pharmacist arranges payment and delivery with the patient or the patient's caregiver. The patient decides if and when to have the drugs delivered, and if and when to take them. There is no longer a requirement for the patient to fill out a final attestation form 48 hours before taking the drugs. Now, the attending compiles paperwork to report to the health department, both after the prescriptions are sent in, as well as after the patient dies. And the health department compiles statistics about that final day, how long it took the patient to die, whether there were any complications, and they add this to a database. Now, these are some important things to keep in mind. The usual cost for the drugs is $2,000. And life insurance is prohibited against discriminating against people who take this option. And the death certificate will list the terminal illness, not that they did PAD or used the EOLA. Nurses can be in the room with the patient if they feel comfortable with that. I usually try and be present with my patients when they're taking the medicines, mostly to help instruct them and comfort the people who are there witnessing. And nurses can obviously come in for reporting death, as we do for other patients. And throughout this process, the patients are given multiple reminders of their right to rescind the request at any time or to get the drugs and decide not to take them. In fact, a fair number of people have the drugs delivered and then just keep them nearby in case they do decide to take it, but end up dying from their disease without ever taking the medications, just having the peace of mind that if they needed to, they were there. So everyone asks, what drugs do we use? Well, there's pre-medication, and then this is followed by a slurry of elephantine doses of morphine, amitriptyline, digoxin, diazepam, and phenobarbital, obviously designed to stop the heart and stop respiration. Generally, the patient goes into a deep sleep within just a few minutes of taking these drugs, and death usually follows within about an hour or two, sometimes longer, depending on their drug tolerance and other circumstances. Here are some points about the new law that went into effect this year. A shortened waiting period between verbal requests is a big improvement, but pay attention to the documentation that needs to be done. So it requires now that you document when a patient makes this verbal request, and if they submit a written request, it needs to be in the medical record. You have to provide those records to the patient should the patient transfer to another provider. And if you don't participate in physician-assisted dying for a patient who's asking about it or requesting it, then you must inform the patient of that and document this in the medical record and the reasons why you don't participate. Again, there's no penalty, but the law wants this to be documented based on bad events that have occurred over the past few years. It also requires your healthcare company to post on its internet website its policy regarding participation in the End of Life Act. And that's to help prevent patients from being referred to agencies that don't participate if that's what they're interested in doing. Here is what I ask of you. I would encourage you to become familiar with the Act and to consider participating. These cases are truly tragic, and the gratitude of patients and their families is overwhelming. I have attended several cases and can vouch for this. Let me end with this. Every person's life is a story. The End of Life Option Act allows one way in which a person can write the way they want that story to end. Thank you.